I am absolutely delighted that we have a speaker of the calibre of Professor James Ward, who in our hour of need said, sure, I can give the opening oration. And I've heard James speak before, and he is an authority very much in his own right. He asked me not to go too much into his biography. He's a very modest man, but it is quite an exceptional background that he has. He's worked in rural, remote, urban Australia. He's held senior positions in a number of institutions. He's got a very formidable publication record, including first author publications in the Lancet. So he comes to us with a wealth of scientific and research background and credibility, but also with a leadership position in community. So I can't thank him enough. I am grateful beyond words. And James, it's a privilege to have you come and speak to us and open our conference. So thank you very much.
So yes, I want to really just go back to basics. Who are we? What is health equity for myself? What's decolonising practice? Because I think that's where we need to head to. Addressing how do we get to health equity, addressing social and structural determinants. I want to talk a little bit about research, and then, of course, the voice, given that there's a referendum on Saturday, just some initial comments about that, and then really what the Academy can do to acknowledge First Nations brilliance and excellence. So who are we? We've been on this continent for 60,000 years, and we've survived on these lands for 60,000 years. It's a harsh environment that we've lived in for 60,000 years, but we've managed to survive, and we are very connected family-wise, kinship-wise, and for us to operate on this land for 60,000 years, we need to have our family, our kinship systems in place, our spirits in place, our land is part of health, our dreaming is part of health. And all of that being in balance is what has driven health for us for over 60,000 years. In my language group, Pinjarra and Narungga peoples of Central and South Australia, there are 5 names for elders in traditional language, in Pinjarra language. And so our people used to live very much a long life expectancy. And unfortunately, a lot of that's been undone in the last 200 and so years of colonisation. We were incredible with sustainable and environmental stewardship over this country. We had equitable but prioritised sharing of resources between clans and within clans. We had very organised societies. We had the tools and technologies, and we adapted for over 60,000 years on this country. And we were very much an egalitarian society where we didn't have haves and have-nots. And we had very complex systems and ways of being and knowing. Sign language, our kinship systems about who respect, about who could marry who, within clans and across clans. Very complex ways of being organised in society's ways. And so health equity for me is not only about the absence of disease, it's obviously the absence of disparity in disease outcomes and mortality. It's also being that there's no disparity in access to healthcare nor utilisation of health services. It's about a fair, just, equal system and structure. It's achieved when our livelihoods are in balance, our social, cultural and spiritual beings are balanced. And it's difficult to achieve in this place where there's been so much damage amassed through colonisation, creating much trauma, intergenerational trauma and grief for our population. But for many of those imbalances, they're nourished or filled up by our own people in the current situation we're in and being on country. They're 2 things that really fill my cup, is being on country and our own people, being among our own people. I wanted to put this slide up because equity is talked about as the end game, but actually I feel like we need to be liberated from equity and we need to go much further. We don't need to only achieve equity, we need to be liberated from equity. And so I'm going to spend a few minutes talking about liberation. So it's about equal, fair and just outcomes for our people. We'll be liberated when there's no need for a special program for us. It means we won't have a need for a voice. It means we will be looked upon as equal citizens in this country and not the ones who drag the place down. or not those that need special benefits, often has come to the forefront in social media over the last few weeks. And when there's no need for a session like this in the academy. But more importantly, it means we don't have to spend significant times in hospitals as kids, where we don't go to numerous funerals of people who are way premature to die. It will mean we don't see the stats that become so ingrained in our daily lives that we become fatigued of them. And it will mean we don't define our elders as people in their 60s or sometimes younger, and that we will see our people live to the 80s and 90s and 100s, like I see my colleagues who are non-Aboriginal with their elders in their communities. I rarely get to see an elder in my own population who's made it to the 80s or 90s. My mum passed away when she was 65, a real shame on this country. And that's what it means to be liberated for our people. The root causes of health equity really are framed, and people, organisations and entities like the AIHW really frame the root causes of health inequity as the social determinants of health, behaviours of our population, and self-service delivery and access to healthcare and utilisation of care, plus the health workforce. But actually, there's a whole lot more that contributes to health inequity. And that is the colonisations, the haves and the have-not, the ongoing socioeconomic disadvantage created by colonisation that has never been undone, despite what Jacinta Price says, who's a Warlpiri country woman from Central Australia, where I grew up. It is also about the intergenerational trauma caused by colonisation and its ongoing detriment. It's about policy development, implementation, and lack of accountability to progress outcomes for our population. It's about racism. It's about stigma, discrimination, and stereotypes for our population. And it's also about the environments we live in, nutritious and affordable foods, sporting infrastructure, which is missing in many of our populations across this country. The ABS, as I said before, really categorise health inequity as being contributed to 47% of the gap between Aboriginal and non-Aboriginal people in this country is due to access to health services and the impact of cultural and historical factors on health. 34% is due to the social determinants of health, and 19% is due to our health risk factors. Now, the one that gets talked about the most is the one that least contributes to health inequity, our own behaviours, and that is the problem in this country. Indigenous people who live on country were more likely to assess their health as good or very good or excellent compared to those who didn't. And so another ongoing impact of colonisation. I want to talk about the Close the Gap agenda at the moment. There are 4 priority reform areas under the Close the Gap, and these are formal partnerships, decision-making, transforming government organisations, privileging the community-controlled sector, the Aboriginal community-controlled sector, and shared access to data and information at a regional level. Close the Gap as a strategy has been in place since 2007, and currently we have 17 socio-economic indicators that have been worked on. I think we've previously had 8 or 9 indicators, but the latest iteration of Close the Gap has 17. And they cover a whole range of things, but there's a lot of things missing there that really will make a difference, I think, from this Close the Gap agenda. The Close the Gap agenda, the report this year, I don't know where the 19 comes from, but there are 17 indicators, socioeconomic indicators. 4 are on track, 11 are not on track, and 4 can't even assess a trend of where we're going to. It's been in place since 2007, remember, Close the Gap, and yet we are struggling big time. An estimated $50 billion has been put into closing the gap. And so it makes me question, were these targets too ambitious? Were they too crude to capture what we really need to do? There was major reform expected, yet no major reform in how we did things. For instance, schooling is a big focus and Close the Gap. You just continue to do things, expect kids to show up in places that are culturally unsafe for our kids to show up. No major reform, but yet expected the same, expected different outcomes. And so really it needs a major shake-up if we're going to continue on that path. And very little was offered in understanding what the best buy initiatives were to help close the gap for our people. As we move forward with closing the gap, I think we absolutely need to unpack racism. And we've seen racism at its worst over the last little while in the lead up to this referendum. But racism at all levels, the systemic issue, not sure we can ever do this when this country was colonised in the way it was. How can we ever ameliorate racism in the way that this country was? But we do need to work on it, systemic racism, personal racism, and at the institutional level. And I think at the institutional level, we can do a lot of good work at reducing racism. We need to get better with getting all of our providers culturally competent. We know when Aboriginal people are involved in out-of-home care for children, that they have much better outcomes for those kids compared to non-Aboriginal people. But when non-Aboriginal people are trained up and they're culturally aware and sensitive and competent, they can have as good outcomes for those kids. A report from WA. I think we need to envelop trauma-informed responses in all that we do. There's a major workforce crisis for our population across the whole health sector, but really impacting many communities in Australia for Indigenous health. Many communities, especially exacerbated by COVID, many community clinics closed down in remote areas because of lack of workforce. And that's unacceptable. It's just unacceptable. The last few weeks, I was up in the Torres Strait, and you have allied health professionals visiting the outer islands of the Torres Strait once a year, if lucky. If those people are out of the thing, that means they don't have access to a physio, to OT, to rheumatic heart disease screening, to really basic essential services that are required for communities. And so it's here on our doorstep, and and many communities suffer this same issue. More focus on Close the Gap should be around the realities that Indigenous peoples face and survivorship, and bringing in some Indigenous paradigms of survivorship and relationality, land, spirit, family, bringing all that into the fold of healthcare policy and delivery, and shifting this major discourse that exists from government, particularly those in Canberra, that say the real blackfellas live in the bush, and those blackfellas that live in the city, they're doing all right. They have access to the hospital, they have all this. But actually, if you look at health outcomes for people in the city, for blackfellas in the city, 60% of the gap between Indigenous and non-Indigenous Australians is driven by urban populations. It's where the majority of our population live, but you never hear that discourse from government. And so I think really changing this discourse from all of us being involved in our efforts to close the gap for our people. And much greater effort needs to go into Indigenous data sovereignty, and I'll talk a little bit about that in a moment. So what can we do to liberate ourselves from inequity? So I'm going to talk a little bit about decolonising our systems and structures. Making healthcare systems and structures right, addressing social determinants of health, work on eliminating racism, enable self-determining nations and self-funded nations into the future. And so decolonising our practices and structures and systems. It seems a scary word to decolonise, but actually it's not that difficult, I don't think. It's putting power into Indigenous peoples. It means dismantling some of the structures that perpetuate this status quo, addressing unbalanced power dynamics in our societies. And that's it involves removing the underpinning social inequity that was exacerbated by colonisation and has never been undone since. And yet we haven't started to do this yet. And so I really feel like, especially after this weekend, when the result's looking like it will be, that we need to go on a radical change of the way we do business with blackfellas across this country. Decolonisation means accountability, and I don't think we have enough accountability for our people. It's not acceptable that we have ongoing rates of the rheumatic heart disease the way we do in our population, or in the areas that I work, very high rates of STIs and bloodborne viruses, or poorer outcomes in vaccine preventable diseases. In all of those areas, I think we need to do much better. And it's what we've always done with each other. Our clans and communities have always been accountable to each other, and we call each other out, and we do it very well. I think we have to be much more accountable with government. Decolonised health recognises the way we consider health, and the way we consider health is about country and kinship and our stories, what's gone before, and who's coming after us. And so decolonising also involves, this country hasn't done it yet. Canada's done it ahead of us, but we haven't been through a truth-telling process. And until we do that, we're just going to maintain this status quo. I feel is that we haven't really told. We've had things like Bringing Them Home report, the narrative about stolen generations and the harrowing stories of hundreds of thousands of Aboriginal children removed. There's some unfolding events that are happening, burial sites at some of the places where Aboriginal kids were, like they found in Canada. This place, we really need to go on a truth-telling mission if we are to move forward as a nation with real equity in sight. Decolonising education, if we can start young, if we can start telling the truth to kids at school and in our universities, I think we will be headed for a better path. Empowering our own people, and I'm not saying we need government handouts, as is commonly said, but we need to empower our people. We need to lift up our people. Our people have got agency. Our people have got brilliance, but we're never allowed to show it, and we're never given the latitude and freedom to be able to shine in the systems that we work in. How about we talk about redistribution of wealth in this country? If we're really going to achieve equity, let's redistribute the wealth in this country. And that is about land. It's about recognition that our land was never ceded. It's about recognition that we don't all have intergenerational wealth. And I'm not saying every blackfella. There's a lot of blackfellas now that are middle-class Australians. And I'm not saying every blackfella needs this hand up, but I think there's a lot of our population where we could do some really innovative things around taxation, around remuneration for people who have really been done hard by in communities who have been put on missions and away from their traditional country and never been able to return back to country. Those kind of innovative things need to be thought about by government if we're really going to move forward on this equity issue. And I think reforming the legal and political systems is really critical. It's a big thing to ask, but it's but I do think the way that we do business, and this whole thing about the voice, is really trying to reform a political system where there hasn't been enough voice by Aboriginal people within the in the political system for us. Importantly, I think this really needs to happen, is reform the media. Media have demonised us. They've played a really smart game over the last in this debate around the voice. I think they've really played a smart game. They've always had a no proponents, and they've always had the yes, but and it's great that there's some balance there, but actually I think they played a really big role in what we might expect on Saturday. The challenge really is to operationalize all of those things. I said I'd talk about Indigenous data sovereignty, and I think this is really critical if we're to move forward. Indigenous data sovereignty uses a whole range of principles: ownership, control, access, possession, collective. Our data needs to have collective benefit. We need to have the authority to control it, responsibility and ethics. And essentially what Indigenous data sovereignty is getting the data out of government and into the hands of people who need to make sense of that data. It's about us having good data, the right data, complete data, accurate data for us to make the decisions about where we go to from here. And it's for us to analyse and interpret that data. And there's enough Aboriginal people to analyse and interpret and to make sense of our data now. Decolonising health and public health particularly is about addressing racism, because racism was an instrument of colonisation, and racism at both at systemic, personal and institutional levels needs to be addressed. And racism is actually was the tool they used for colonisation. It was the superior against the inferior, and we need to unpack it. And whether that's harsh or if it's too ambitious or not, we absolutely have to unpack it. Making healthcare right. We need to have more Aboriginal community-controlled health services across this country. There's still patches of this country where there are not enough Aboriginal community-controlled health services, and the community-controlled sector, particularly in the primary sector, has really exemplified how to deliver primary care to communities where there's significant trauma and social disadvantage. There needs to be some thinking about the models of care, particularly in primary care, and IUI, who are based here in Brisbane, the Institute for Urban Indigenous Health, really got this nice model of care that they're trialling, an integrated system of care where the same patient sees a pod of clinicians every time they come to the clinic. The same set of clinicians. It's a social behaviouralist, a nurse, or a doctor. They see the same clinicians. It's a pod. Really nice teamwork, and they're having really great outcomes from already a very good system of care with this new model of care. We're about to do a very large data linkage project between IUI here in Brisbane and Metro North, the large hospital and health service here in Brisbane, to really understand where the drop-off is in between Aboriginal people from the primary care system to the tertiary system. Where are their strengths in that system and where are the gaps? Because nobody's ever done that before. And until we can get that pathway right, until we can reconfigure those pathways, then we're losing a lot of our patients in that care pathway. Inclusive practice and, of course, community-controlled, Aboriginal community-controlled organisations really have much better outcomes, and there's a whole range of evidence to say that Aboriginal community-controlled health organisations have superior outcomes in health that compared to mainstream healthcare services. Addressing the social determinants of health is really an issue that rarely gets talked about, and it's not a researcher's role to address social determinants of health. We're not funded in research really to address social determinants of health. But what really needs to be done, particularly I'm an infectious disease epidemiologist, is housing. It needs to be addressed. And a lot of the infectious diseases in our communities are attributed to overcrowding and not enough housing stock for our population. And now it's an expensive proposition for government, but it's actually unfinished business for a very long period of time. Now governments have got themselves into a situation where it's such an expensive proposition, they don't know what to do about it anymore. But we're going to be in this fold of not getting significant enough outcomes for our population until we address housing. And also addressing socioeconomic disadvantage, education, employment, and income particularly are important factors to address that. And that's what Close the Gap is trying to address, a really holistic look at health. But unfortunately, we are not on track with most of those determinants of health indicators under the Close the Gap agenda. Importantly, infectious diseases, I'll just spend a minute on this. Infectious diseases were first noted in the first National Aboriginal Health Strategy. I picked up the strategy a few months back, and really RHD was mentioned there, tuberculosis was mentioned there, and STIs were mentioned there, the areas that I work in. TB, we had an outbreak in the Anangu people recently. A child died, and really this is unacceptable in a country like Australia where we've got TB. And mortality related to TB in a population. Since then, we've had many disease and population-based strategies, lots of policies in place, a siloed piecemeal approach, but with very little accountability. And I'm a researcher and I've been working in the area of infectious disease for 20 years now, and really I haven't shifted prevalence. And it's because we're siloed in what we're trying to do. We're trying to get our systems right, our healthcare systems right. But if you've got overcrowded housing and if you've got people with lower education and income that can enable people to go to healthcare clinics or are empowered about healthcare clinics, we're not doing the right job for our population. And I'm as accountable to my own population as the government should be to our population. I'm probably much more accountable. And so really what they are policy failures. What we see is they're major policy failures, because we've had policies around syphilis. We had I'm going to talk about it in a moment, but we had a major syphilis outbreak in 2010 in northwest community of this state here, that has amassed around 5,500 cases now among young Aboriginal and Torres Strait Islander people who are going about their daily lives, having relationships and sexual activity with their peers, but unfortunately acquiring an infection like syphilis. It's unacceptable. RHDs, other STIs and bloodborne viruses. Now, research, I'm a researcher, and Steve Westling's not in the room, so it's okay. But I know I've had these conversations with Steve for a long time now. Our role is to create new knowledge, it's to build on existing knowledge, it's to understand our worlds better. It's about advocacy, it's about advancing fairness and equity, and it's about translating that into policy and programs for our population. But research by its nature is very much a colonial concept. It's very much non-relational, it's very extractive, it uses hard time frames, it restricts how findings can be recorded, it has hierarchical notions of expertise, and ironically, the researchers who are the experts become greater experts by working with the novice and the disadvantaged and disenfranchised populations. They become more experts. And it has colonial discourses of discovery, of frontiers, of working with the populations that need it the most and collecting data from those populations. It's unfortunately a very colonial concept. And if anything we can do in this country is decolonize our approach to research in this country. It can be a tough space, research, and most of our communities are jaded with research. Why do we need more research? We know what the problems are. Many of them have moratoriums in place, because they're tired of researchers like ourselves coming in and hoping to fix up some of the problems. And their aspirations are often very different to the funding opportunities afforded by research. So most people, if I say, what do you want fixed in community, they'll say, better housing here, brother. We want better housing. And research money is not housing. And that's unfortunate, but that's what people want. People know what the answers are. There are some good things that happen in research. It does advance knowledge. It tells us what the extent of things are. Unfortunately, always opens itself up to more research happening in our communities and finding more answers to the same problem that we've been trying to address for a long period of time. And to be honest, research can be a little bit soft. It's not potent enough, and it's often framed in ways to be palatable for communities. And that's unfortunate. We've got a $2.5 million grant to fix up 235 years of damage. And that's what it is. But I am a researcher, and I will try and do things better for our population with the agency I have as a researcher in this country. So research, for me, I've been working in the area of STIs for a long period of time. STIs are easily tested, treated, diagnosed, cured. Nobody should have STIs in this country. But you wonder why we're not getting the right outcome. It's about the potency of the strategy, I think. It's delivering the potency of that strategy at the right time for the right population, at the right point in time, and for the right length of time. And a 5-year grant is probably not enough to be able to deliver on that. The potency of a strategy needs to be talked through with communities, and often we do it in a way which is palatable to communities, and often we do it in a way to get it through the review panels who are reviewing our grants and saying that's far too ambitious a grant, so we're not going to fund it. And so we're caught in a system of creating further disadvantage for our population. If we can decolonize our systems, including research, we can make our way to equity. And in all fairness to NHMRC, they come up with the new Synergy Grant. And the Synergy Grant, I think, really suits Aboriginal communities really amazingly. It enables multiple disciplines to come together to answer a single question. A Synergy Grant. It's a $5 million grant, it's a 5-year program, but it really is an amazing opportunity, because actually the single intervention, if I talk about STIs, the single intervention that we've been trying is CQI. That's one intervention. Point of care machines is another intervention. Health education and health promotion as another intervention. They're all single interventions. If we could put all of those together in one application, in one grant, and work solidly with community, then we will have some outcomes. But you know, we were the first group in Australia, in the world actually, to trial point of care machines in remote Australia for STIs. And what we did with those point of care machines, so people got their tests and they got the results within 90 minutes for chlamydia and gonorrhea. They're only as good as the people that come through the clinic door. They're good on the day. Males only make up a third of all point of care tests now. So males are not coming to the clinic. So we need both males and females to be tested. Males are still coming to the clinic less. And the real problem with the point of care machines is that the good thing about the point of care machines is you can get interval time to treatment down. So that prevents PID, particularly for women, if we can get treatment interval time down. But what doesn't happen is retesting at 3 months. Still only 10 or 13% of people are retested at 3 months. And this is across government services in remote communities. And I see Taryn up there, but really precision public health, when I come across this literature a few years back, I really thought this is it for us. And it's really trying to embrace all that's available to us. And this is what we're doing with 2 studies right now. We're bringing together notification data, health services data, qualitative data, genomics data, social determinants data, mapping it at a local regional level in 3 areas of Australia, then saying to the community, this is what your data looks like. This is what it looks like. What do you want done about it? Here is a set of interventions for you to consider, but which one of these is most palatable to you? And so that's what we're trying to do with this precision public health approach. It's a very different approach. And I got those 2 grants through NHMRC without having an intervention named in there. But it's absolutely the right way to do research. Go to community, not with the intervention named in the grant, and let communities determine what's the best approach with that grant. So finally, on the voice, it's really giving Indigenous peoples a voice is a decolonising practice. We'll go to vote this weekend. Some of you have probably already voted, but we're aiming to change the racialised constitution of this country and have our voices amplified within government. I'll give you an example why I think there's a need for a voice in Australia. This one, the syphilis outbreak I mentioned before, and I'm going to mention COVID and hepatitis C, 3 areas that I work in. So the syphilis outbreak, I wrote a paper in 2010 to say, now might be a good time, Australia, to eliminate infectious syphilis from Aboriginal communities. We had the numbers dropped down from 350 down to 129 in 2009. Wrote a paper, we could only get a little bit more emphasis, government funding, to get rid of this from our communities, we could have eliminated syphilis. Little did I know at the same time there was an outbreak happening in a far northwest community of Queensland here. And at the same time, Campbell Newman, the Premier of this state, had decimated all public health services to be able to respond to that outbreak. That outbreak now has spread across into the Northern Territory, into WA and into South Australia. We now have a rate of syphilis 8 times that of non-Aboriginal populations. We've got now more than 5,500 cases of syphilis. And I was involved in all that period there on the Ministerial Advisory Committee for STIs and bloodborne viruses. And myself and another champion, a non-Aboriginal guy, sexual health physician from Cairns, were advocating all the time for something to do about it. And the answer was, it's a state and territory issue. It's not a Commonwealth issue. And we had no leadership from 2010 to 2015. And then we set up a multi-jurisdictional syphilis outbreak committee. And by that time, it had moved into 3 jurisdictions. And so now it shouldn't be really an outbreak anymore. It's endemic syphilis, but we still call it an outbreak. But we just, this is unfortunate scenario of blackfellows in this country. COVID-19 is a different story. So COVID-19, I was a member of the Communicable Disease Network of Australia, the only Aboriginal member of CDNA. And before, there's probably members of CDNA who have been on CDNA before. CDNA, we used to talk about foodborne outbreaks on cruise ships every 2 weeks, which was nice, and some immunisation stuff occasionally. And a little bit of STIs. But then when COVID came, CDNA escalated. So we moved to 7 days a week with the COVID CDNA working group. The news out of China and the news out of Spain and the news from Navajo Nation in the United States was that the immunocompromised, the elderly, were all going to be affected. And I recognised very early that's our people. And so CDNA, I rang up Nacho on the 3rd of February, I think, and said, look, we need to do something about this. It's going to impact our people. And we put in place a Aboriginal Torres Strait Islander advisory group on COVID, and CDNA was obviously there for the whole nation around COVID-19. And for the first 2 years prior to Omicron, we had the most amazing outcomes for Aboriginal people in this country. 6 times less the rate of COVID-19 in Aboriginal communities than the non-Aboriginal population, less hospitalisations and very few deaths related to COVID in the first 2 years of that outbreak. And we only experienced a couple of major outbreaks. One was part of Aboriginal people got caught up in the Melbourne outbreak, and then the Western Sydney one that moved into Western New South Wales were the 2 major outbreaks that Aboriginal communities, and no remote community had a major outbreak, which was phenomenal. And that was not only CDNA or the Aboriginal Torres Strait Islander Advisory Group, it was communities stepping up and taking leadership and control of that pandemic. And this is where I think, for me, the voice makes a little bit of sense around the working group had regular advice into the AHPPC and to National Cabinet. It sometimes went to National Cabinet. And this group here, the chair of that, Dawn Casey, often went to AHPPC and often went to the Australian Cabinet during that when we needed action for Aboriginal communities. And so it was a voice within the executive arm of government, and they responded very well. And because they didn't want Australia to have the appalling outcomes like the Navajo Nation had in the United States, or Brazilian Indigenous peoples also suffered amazingly. Viral hepatitis, I'm nearly finished, I must be close to it. Viral hepatitis, we're on a path to no viral hepatitis by 2030, Australia and the world. And largely facilitated by a new drug, which was introduced on the PBS in 2016, a direct-acting agent that cures people with hepatitis C. We've had it, it's available, it can be prescribed at almost any place now. And since 2016, this is a silver bullet for our population and for people living with hepatitis C. Since 2016, we've had more hepatitis C in our community than ever before. And so, and this is about a strategy, eliminate hepatitis C in Australia, that has no voice within the government. And so I think we really need to do much better at getting government on board with some of these issues. It's very unfortunate that we've had more cases of hepatitis C than before, when nobody should be getting it. If we think about what's happened with HIV in this country, treatment as prevention has really worked, and 200 cases of hepatitis C of HIV occur in the Australian population now. And yet we've got 1,400 or 1,500 cases of hepatitis C in our population each year. Finally, just recognising, acknowledging and respecting Indigenous brilliance and talent. Within this academy is one level, but within all of your institutions, I think really needs to do it. I think advocating for change within your organisations to recognise, to privilege Indigenous voices needs to happen. About mentoring, promoting and recognising excellence way beyond your reconciliation action plan. It really needs to think outside the box if we're going to move health equity. And we need to think outside this prevailing deficit discourse of our people, because we're not. We're brilliant. We've survived on this planet for 60,000 years. Promote representation, inclusion at all levels within your organisation or within your community-based organisations. It doesn't matter, inside or outside the work. Be bold and go beyond tokenism, because that's what we need. As we move forward, we've all got a responsibility to achieve equity, and we owe it to our ancestors who paved the path for us, and we've got to pay it forward for our next generations. Thank you very much.
Very fitting that James ended his slide with recognising brilliance and talent. I would love to this audience to acknowledge the brilliance and talent of James Wonder. And sincerely, James, I can't thank you enough for an outstanding presentation delivered at a minute to midnight. So thank you so much powerful language in there and powerful ideas. We do have a couple of minutes for questions from the audience. And James, I might start while people are getting microphones and moving those around. You've articulated some really powerful concepts here about decolonizing. But the systems in which we all live right now are kind of catered for incremental changes. And some might say your proposals are radical. How do we move forward? Do you see a way that we can implement these kinds of decolonizing practices? Is incrementalism going to get us there?
Yeah, I'm not suggesting that we all dump everything and move towards decolonizing everything. I think it has to be done incrementally. All of us have to do it. All of us have to be on the same page. I think a truth-telling commission in this country is required, so we can all be on the same page. Because at the moment, I think there's great division in this country. It's really shown in the last month or two. There's great division in this country about what we get and what we're supposedly getting, and how privileged we already are together. I think absolutely at an organisation level, start to think about it. Racism is easy to kind of stamp out in an organisation. Think about your policies. Think about behaviours is obviously already legislated, but policies often are not thought about, and there are many policies that impact on our people. Mentoring and privileging Aboriginal excellence is something we all should be doing already, and if we're not, then we need to question hard. I started at this university, at UQ 3.5 years ago, and there were 7 PhD students at UQ when I came, and 4 of those were Aboriginal. They've all finished now, but they're not. That wasn't part of my brief. But in the last 3.5 years, we've got 24 PhD students, and half of those are Aboriginal and Torres Strait Islander. And so our people are there. They're just not afforded the opportunities. And so I think all of us have a responsibility to shift the academy. And that took some shifting of the academy to get our people involved in the academy. And it's also, it's no easy feat, that's for sure. Trying to get them finished is the challenge now, and all of them have progressed. Well, actually, that's in my own organisation. There's another 10 that were started in the Health and Behavioural Sciences faculty, and 9 of those are doing their PhD. And so that's a massive number of Aboriginal people who are in the academy. And so it just takes some insight to get out into community and understand who's out there and providing opportunities for people. I think there's plenty of scope. It's just that I think for a lot of people, for non-Aboriginal people, you find it very difficult to kind of navigate that system. I think in all fairness, it is very difficult, but I think you need to find a buddy and find the right organisation or the right people. There are amazing people on the panel next who are working in organisations who are all doing the same thing, trying to advance our own people's status in this population.
Thank you. I can see we have a question from Ingrid.
Yeah, thanks, James. That was simply outstanding. And the Academy is very keen to increase its number of fellows. We have 4, which is 4 times the number of the Academy of Science, but we want a lot more than that. What I wanted to ask you about is that we're very focused on mentorship, and we have a mentorship program of which we have a number of mentees here who are already, it's highly competitive, they're already on their way in that trajectory. We also have another program aimed at medical students, science students, to try and get them to think about being clinician scientists. And we've long talked about what can we do in the Indigenous space because we don't want to tread on toes, but we would like to really try and encourage young Indigenous health and science professionals to think about this. And I've wanted to run a specific Indigenous program tailored specifically, but I'm really keen to know whether you think that's a good idea, a bad idea, how you go about it.
I think it's a good idea. I do. I think you've got to have the right people involved. You've got 4 Academy members, Alex, Ian, Sandra, well, so Pat, all involved in the Academy. I think you should really tap them on the shoulder and bring them to the table and say, look, this is what we can throw at it. Can you help us along? Can you, if they're extremely busy people, I know, but if they can't, can they nominate some other people? We've got a mentor program, a mentoring program for the new Academy, for new Academy members here in UQ. And that program is not to replace what the supervisors are meant to be providing for HDR students at all. It's meant to be the stuff that they never get taught in the university, which is Indigenous paradigms and theories and standpoints and advocacy stuff. Advocacy, how do they make a difference in this world in this complex world that we live in? And so we're exposing them. There's a number of other mentorship programs around. The Poche Centre in Melbourne run a Indigenous leadership program. There's a number of programs around. Experiential learning, I think, is really important. Exposing people to different organisations and faculties, and the Poche program in Melbourne takes people overseas to Harvard and to not to Harvard, to Oxford, and last year they went to Canada rather than the UK. But they, those kind of programs are really well received. I think you've got to start small and see how it goes. There's other scientists. There's basic scientists. Misty Jenkins is at Walter Eliza Hall. Like people like her, we have hardly any basic scientists who are Indigenous across all the laboratories in Australia, and that I think is a real real gap in where we need to go to. It's a real gap that needs to be filled. Yeah.
Thanks.
I think we have time for one more question from the microphone there.
James, excuse me, James, thanks very much. That was an amazing presentation. I'd like you to reflect a little bit more on the differences you see in the government's response and your own people's response to COVID versus hepatitis C, which you mentioned, but also rheumatic heart disease. It can't have just been the vaccine, because you became active in this space before the vaccine was available and were able to control the disease by public health measures in Aboriginal people. Why isn't the same commitment there to diseases like rheumatic heart disease, for example?
Sorry, what was the last part? Why
isn't the same commitment there for diseases like controlling rheumatic heart disease?
Yeah, our people know why rheumatic heart disease exists. It exists because it's a disease of poverty and overcrowded housing. Now, we're on the pathway to developing a vaccine for sure, but a vaccine is not going to be the only problem. It'll probably shift another problem. And I think we need to be very careful about these silver bullets that we're developing, because the overcrowded housing will be a neglected area for forever if we have the vaccine for strep A, if we have a vaccine for strep A. And I think, we've got to hold government's account to it. Like, the first funding announcement from MRFF was the $40 million for the strep A vaccine development. And government response versus community response. Community was incredible during COVID. Community responses. Communities exercise their sovereign rights by closing off their communities. Communities exercise their sovereign rights by putting out COVID messages in their own languages. I woke up one morning, the Northern Land Council in the Territory had translated what COVID is, how it's transmitted into 19 languages of the top end. It was incredible. And I've never seen that kind of action before, but our mob knew. People think our mob don't care about our health, but actually our mob extremely think hard about our health. And I kind of feel like it's for many in our population, it's a too hard basket to try and address it. But there are plenty of great things happening out in communities. I don't know if that answers your question. The silver bullet for hepatitis C, I just feel like we just missed the boat. We've gone in thinking that the silver bullet would fix up treatment as prevention. It's a strategy, treatment as prevention. But actually, for people who are injecting drugs and people with hep C, they've got really complex trauma trauma in their lives, and actually the drug doesn't actually matter to them, really. They've got other things to worry about. And so this is where Indigenous lenses have got to really come into this space, because they're framed in a non-Aboriginal way, and what works in non-Aboriginal population doesn't work with our population. And I don't know, that's 101 of Aboriginal health a long time ago, and it never gets talked about anymore, but I think we have to get back to that. Yeah.